Swayam Prabha. Digital India. Educated India.
There are 4 types of acid-base disorders. This is the last of them that we are going to discuss now. Respiratory acidosis. The decrease in pH in this condition is due to an increase in plasma carbon dioxide. pH is dependent on the ratio between bicarbonate and carbon dioxide, and when carbon dioxide increases, a corresponding increase in bicarbonate can limit the change in pH. That's what would happen normally, where the kidneys would compensate by putting out more bicarbonate, limiting the change in pH. Respiratory acidosis can be compensated for, temporarily at least, by the kidneys. In respiratory acidosis, almost always arterial oxygen concentration will be lower. Remember, when we discussed respiratory alkalosis, we discussed a set of conditions called hypoxic hypoxia, which was also referred to as type 1 respiratory failure. In this condition, there is hypoxia, a reduction in oxygen concentration, but carbon dioxide levels are normal or actually low, they are not high. That's what was referred to as type 1 respiratory failure. Respiratory acidosis is a condition where carbon dioxide is high, and when carbon dioxide is high, almost always oxygen will be low. This is what is referred to as type 2 respiratory failure, where both gases are affected. This may be referred to as an obligatory hypoxia. The details will be dealt with in respiratory physiology. Just like respiratory alkalosis coming up due to hyperventilation, respiratory acidosis is due to hypoventilation, and the term hypoventilation technically refers to a state where the amount of carbon dioxide exhaled is less than what is produced. If that much is produced, less of it is released so that the remainder builds up in arterial blood. If this is an ongoing increase in carbon dioxide levels, that is, if lungs are putting out less carbon dioxide than what is formed, and the respiratory acidosis is developing, we would call it a non-steady state condition. This is an acute or a subacute state. However, if carbon dioxide levels have built up to a certain level, and after that, if it stabilizes there, and if then whatever is produced is eliminated, albeit at a higher arterial carbon dioxide level, that condition would be referred to as chronic respiratory acidosis, where there is acidosis, but the individual has reached a stable state, a steady state condition, where after the increase in carbon dioxide, ventilation matches carbon dioxide production. Why should there be an increase in carbon dioxide? We don't know. Maybe the central chemoreceptors have reset themselves to respond to a higher level of carbon dioxide. There are other terms which would refer to this state. Respiratory acidosis can also be referred to as hypercarbia, hypercapnia, type 2 respiratory failure, or asphyxia. Carbon dioxide levels are normally 40 millimeters mercury in arterial blood, and when we call it respiratory acidosis, the levels have gone up to more than 50 millimeters mercury. That's the clinical definition of hypercarbia. To be technically correct, any acidosis with a carbon dioxide more than 40 to 45 millimeter mercury would be respiratory acidosis, but to call it respiratory failure, the clinical definition is that carbon dioxide must be more than 50 millimeters mercury. Hypoventilation is therefore the cause for respiratory acidosis. Not only that, normally carbon dioxide in the atmosphere is about 0, but if the carbon dioxide in the atmosphere is higher, carbon dioxide can enter circulation, and that is an important cause of respiratory acidosis. The examples being inhalation of exhaust fumes, vehicle exhaust fumes. We will see 2 news items at the end of the session where carbon dioxide entry could have occurred. Let us move on to causes of respiratory acidosis. We have seen earlier that these are all stimuli which can act on the respiratory center. In respiratory acidosis, the respiratory center does not work as well as it should. It does not respond to an increase in carbon dioxide. That is why there is respiratory acidosis. We can now remove all those stimuli. We will not be considering them. They are not going to induce respiratory acidosis. So, normally any increase in carbon dioxide will stimulate the respiratory center, adjust ventilation so as to remove the excess carbon dioxide. Let us say the set point for the central chemoreceptors is 40 millimeters mercury carbon dioxide in arterial blood. If it goes a little more than that, ventilation will be adjusted to correct the carbon dioxide. So, if there is respiratory acidosis and a high carbon dioxide, then obviously the chemoreceptors are not responding well enough, their set point has gone higher probably, or the respiratory center is not responding. This stimulus driving the respiratory center is called the chemical drive, where carbon dioxide or acid drives the respiratory center. The other drive is the hypoxic drive, where hypoxia can drive the respiratory center. In respiratory acidosis, we just considered that the chemical drive is somehow not working. That is why carbon dioxide is built up. And in that state, the predominant drive for respiration is the hypoxic drive. This is very important because in such a patient who does not have a robust chemical drive and is actually building up carbon dioxide, if you remove the hypoxic drive, say by administering oxygen to the patient, death can ensue. If there is a patient in casualty who has difficulty in breathing, inadvertent administration of oxygen can kill the patient if his difficulty in breathing is associated with hypercarbia. We will now look at the mechanisms which can lead to a decrease in ventilation. Respiratory acidosis is due to hypoventilation, and hypoventilation could result due to a number of causes. We will see as many as possible here. The respiratory center and medulla oblongata can be depressed, or the neurons going from the respiratory center to the cervical segments of spinal cord can have problems. These are referred to as upper motor neurons. Neurons in the spinal cord, in the cervical segments of the spinal cord supplying the diaphragm, what's called the phrenic nerve, the lower motor neuron, there could be problems here. The other lower motor neurons would be those from the respective spinal segments going to the intercostal muscles, which are also contributing to respiration. Or there could be problems in the muscle itself, in the diaphragm or the intercostal muscles. There could be problems in the neuromuscular junction. Then there can be problems in the lung itself or the chest wall. For example, rib fracture Rib fracture can cause pain during respiratory movements, and that can limit respiratory movements and therefore lead to hypoventilation. The term ventilation refers to the amount of air going into and out of the alveoli, alveolar ventilation. We will first consider lung diseases and see which of those lung diseases can cause respiratory acidosis. In the previous session, we saw a set of lung conditions: alveolar edema, interstitial edema, consolidation. When they are not very extensive, they can in fact lead to respiratory alkalosis. They will cause hypoxia, a consequent hypoxic drive, stimulating ventilation, and therefore blowing off excess carbon dioxide, resulting in respiratory alkalosis. So, not all lung pathologies will affect transport of both gases. There are only some lung pathologies where carbon dioxide would have gone up, respiratory acidosis, and in all those cases there will be a reduction in arterial oxygen, which is what we call type 2 respiratory failure. Now, let us consider the lung pathologies and see which of them will cause respiratory acidosis. If these are alveoli, and that's a cartoon of a bronchiole. Of course, there will be many bronchioles within the lung tissue. I am just showing one for representational purposes. These are the pleural membranes. Normally, there is no space between the pleural membranes. A space is shown here just to say that there is a potential space. These are almost in opposition to each other. If fluid collects between the two membranes lining the pleural cavity, the visceral pleura and the parietal pleura, this is referred to as pleural effusion. If there is pleural effusion, the alveoli in the base of the lung may have collapsed as well. So, we can call this pleural effusion and we can call this collapse of alveoli, atelectasis or collapse of alveoli. Will there be a respiratory acidosis in these conditions? What we mean is there may be a decrease in oxygen, but is there an increase in carbon dioxide as well? Only when there is an increase in carbon dioxide, there is going to be respiratory acidosis. If the pleural effusion is not extensive, oxygen may be low, but carbon dioxide levels will be normal. There will be no respiratory acidosis. Even if the pleural effusion is one-sided and one lung has completely collapsed, the other lung can take care of the ventilation that is required to maintain carbon dioxide levels normal. Only if there is bilateral pleural effusion and if it is extensive such that ventilation is affected, only then carbon dioxide levels will increase, not otherwise. We have seen this case earlier where there is fluid in the alveoli. We could refer to it as alveolar edema if the fluid is due to cardiac failure, for example, a non-infective etiology. If there is an infective etiology, we will refer to this as pneumonic consolidation in acute bacterial infections, or we can refer to it as tuberculous consolidation, which is a chronic disease state. In consolidation again, there need not be a respiratory acidosis. Fibrosis is a condition where the alveolar walls are thickened. There is more fibrous tissue in the alveolar walls. This is a normal one on the other side for comparison. In fibrosis too, there need not be a change in carbon dioxide levels. A thickened membrane we saw earlier will affect oxygen transport, but not necessarily carbon dioxide transport. Only if the fibrosis is extensive, the compliance is so low that in spite of respiratory effort, the lung is not expanding or the respiratory muscles go into fatigue, unable to induce the required amount of lung expansion. Only in those states ventilation will be affected and respiratory acidosis will ensue. Otherwise, in early stages of interstitial fibrosis where there is adequate compliance, carbon dioxide levels need not go up. Emphysema is a condition where there is disruption of interalveolar septa and the alveoli coalesce with each other, enlarged alveolar spaces with less interalveolar septa. In this condition, the bronchioles will be narrowed because there is elastic tissue in the walls of the alveoli, and that elastic tissue being tethered to the walls of the bronchioles is important in keeping the bronchioles open and patent. And when that elastic tissue is less in emphysema, the bronchioles lose that radial traction and therefore have narrowed. Emphysema is therefore classified as an obstructive disorder. Now, this obstruction is something that can lead to respiratory acidosis. It can increase carbon dioxide, and in this state oxygen will always be lower. This is also referred to as type 2 failure. So, type 2 respiratory failure is synonymous with respiratory acidosis. The other condition, which is also classified as a chronic obstructive pulmonary disease along with emphysema, is chronic bronchitis, where the walls of the bronchi are inflamed, there is so much of mucus, and the bronchial lumen has narrowed. It is again an obstructive disease, and here there is going to be respiratory acidosis. We have already seen what happens in asthma. Asthma is again an obstructive disease where there is narrowing of bronchial lumen because of hyperreactive airways. That is, due to some allergy, the smooth muscles in the walls of the bronchioles have constricted, causing narrowing of the lumen. Does this lead to a respiratory acidosis? Just like the other two chronic conditions, we have considered this question in the previous session, and we saw that the most common acid-base disorder in asthma is actually respiratory alkalosis, but in 1/4 of the cases, you can also get a respiratory acidosis. We have now considered lung pathologies where you will have a respiratory acidosis. These are emphysema and chronic bronchitis, which are classified as chronic obstructive pulmonary diseases. We then considered a set of lung conditions and asked the question whether carbon dioxide can go up in these conditions. Generally not, unless the disease is so extensive as to limit ventilation. In spite of these conditions, if adequate ventilation can be maintained, then there is no need for hypercarbia and therefore no respiratory acidosis. Now let us look at other possible causes of respiratory acidosis. There can be respiratory center depression. Respiratory center depression usually occurs in drug overdose, opiates, that is morphine, excess sedatives, anesthetics, even alcohol can cause respiratory center depression. Ammonia toxicity, and what is called the sleep apnea syndrome, obstructive sleep apnea syndrome as a separate entity, and you could read about it. Let us look at diseases affecting the upper motor neuron, that is the neurons going from the medulla oblongata to the spinal cord. The bulbospinal neurons, which innervate the lower motor neurons supplying muscles of respiration. Polio has a predilection to the motor neurons, and bulbar polio can result in cessation of ventilation. Stroke involving the brainstem. Stroke is a cerebrovascular accident, something wrong with the blood vessels. There can be a thrombus, an embolus, or it may bleed. Stroke involving the brainstem can affect the respiratory center. Then there are some diseases referred to as motor neuron diseases, just like polio. The most important among them is amyotrophic lateral sclerosis. Then there are what we call demyelinating disorders, where the myelin sheath around the axon is lost due to an autoimmune disorder. There are antibodies against the myelin protein, and therefore, this loss of myelin around the neuron. you will learn in neurology that myelination is important for improving speed of conduction, and when there is loss of myelination, nerve function is impaired. So, these are conditions where the bulbospinal neurons may be affected. Let us look at a sample of diseases which can affect the lower motor neuron. Again, polio can affect the anterior horn cells in the spinal cord, which are the motor neurons, which will supply skeletal muscles. Amyotrophic lateral sclerosis can affect the lower motor neurons as well. Then a very common cause for respiratory paralysis is cervical spinal injury due to accidents. At the neuromuscular junction, the disease entities are myasthenia gravis, which is an autoimmune disorder affecting the nicotinic acetylcholine receptors on the muscle surface. So, acetylcholine released by the nerve is not able to act. Organophosphorus poisoning, pesticide poisoning is a very big problem in India, and organophosphorus poisoning affects the neuromuscular junction and causes death due to respiratory paralysis. Then there can be myopathies where the muscle itself is diseased. Duchenne muscular dystrophy is a prototype muscular disorder. It is a hereditary condition which causes death due to respiratory paralysis. More commonly, in critical illnesses, there can be a myoneuropathy, and the cause of the myoneuropathy can be varied. It could be due to the sepsis, due to the muscle relaxants that are given, due even to steroids that are administered during the condition. There can be multiple causes, but in critically ill states, there can be a myoneuropathy. These are the causes of respiratory acidosis or type 2 respiratory failure, which is associated with hypercarbia and hypoxia. In contrast, these states are not associated with hypercarbia. There is only hypoxia. They are referred to as type 1 respiratory failure, and just to avoid confusion, we can remove those causes from this list for respiratory acidosis or type 2 respiratory failure. So, to summarize, arterial PCO2 is 40 millimeters of mercury. When blood moves to the tissues, there is carbon dioxide added, but whatever carbon dioxide is added is removed in the lungs, and ventilation will match carbon dioxide production, so that the arterial blood which comes out of the lungs has 40 millimeters mercury carbon dioxide, and that is a very tightly controlled value. Respiratory acidosis will occur when there is inadequate ventilation. If this is an ongoing process and there is continued build-up of carbon dioxide in arterial blood, we would call it a non-steady state condition or a developing respiratory acidosis or acute or subacute respiratory acidosis. But if the levels have stabilized and ventilation is then matched to production of carbon dioxide, we will refer to that as chronic respiratory acidosis. This is something we saw earlier, that in respiratory acidosis, the primary drive for respiration is the hypoxic drive, and one should not give oxygen without putting the patient on a ventilator. If the patient is breathing spontaneously, giving oxygen may kill the patient because we are removing the only drive to the respiratory center. There are two scenarios that I have read about in newspapers, and one was a WhatsApp news item where carbon dioxide from the atmosphere can enter the system, resulting in respiratory acidosis. There have been two reports in the newspapers in the past 10 years or so, and one of them I remember clearly well. There were heavy rains and traffic jam on a major road in Chennai. There was flooding, the cars were all lined up, and after a few hours of the traffic jam, when the jam cleared, there was one car which wouldn't move. And when people went there, they found that all the windows were raised, the AC was on, the motor was running, and there were 4 young men found dead in the car. The reason probably is the flood waters had blocked the exhaust pipe of the car, and therefore the fumes were in the car. All 4 windows were raised, and therefore the people within the car inhaled the carbon dioxide in the atmosphere and went in for carbon dioxide narcosis probably. Not just carbon dioxide, all vehicle exhaust fumes could have done this. The second one is more specific. Dry ice is solid carbon dioxide. It is used for packaging chemicals or food items during transport. So there's this WhatsApp item where a lady, she goes to collect ice cream from an ice cream vendor, large amounts of ice cream packed in dry ice. She places it in her back seat. She drives home and she goes into a faint-like state. She does not even realize, and luckily for her, her husband was able to locate her with GPS, and that's how she lives today to tell her story. Dry ice in a closed atmosphere will evolve carbon dioxide fumes and can be very dangerous. Thank you. With this, we complete the lectures on hydrogen ion homeostasis.